everybody. So in the next 20 minutes, hopefully, I've been tasked to speak to you about sleep disorders and atrial fibrillation. So sleep disorders, there's many actually sleep disorders that can affect the heart, and there's a lot of association between atrial fibrillation. I'm really going to focus on in the next 20 minutes and talk to you about obstructive sleep apnea and how it interplays with atrial fibrillation. So to kick things off, OSA is a very prevalent disease, okay? In the 15 to 30% in Western populations, which is about 1 in 4 chance in males, and about 1 in 10 chance in females. In Kuwait, it's estimated actually to be around 20 to 30%, which is actually roughly a 1 in 3 chance in males, and a 1 in 5 chance in females. So already to start, we have a very prevalent disease, and not only that, you can see on the graph on the left here, it's this disease is also associated with an increase with age. So as you increase, you have a higher age, or as you grow older, you have a higher risk of developing OSA. And in Kuwait especially, the main driver for this is the obesity epidemic. So we have a big problem with obesity. As you can see here on the left, the higher your BMI, the higher the chance that you have obstructive sleep apnea. And we know for a long time now, for example, that if you have obstructive sleep apnea, overall you have a higher incidence of cardiovascular, both fatal and non-fatal cardiovascular events. So if we look here at these graphs, you can see that the patients in red have severe OSA, and this is an observational study, a landmark observational study in the mid-2000s, and you can see that there's definitely an increase in cardiovascular events in general when it comes to obstructive sleep apnea. And then if you zoom in, and since we are talking about atrial fibrillation today, if you zoom in about atrial fibrillation, it's actually even more prevalent. There's a roughly estimated 50% of atrial fibrillation patients have OSA, as you can see from this observational study, compared to the general cardiology patients. So there is some sort of epidemiological link. It's actually one of the strongest epidemiological links when it comes to atrial fibrillation of OSA. And if you look at OSA patients and you look at risk factors and you correct for covariates, you find that atrial fibrillation is one of the strongest associated factors with obstructive sleep apnea, stronger even than neck circumference, hypertension, and even body mass index. So the question now that I've shown you that there's a strong epidemiological link between these two diseases, they're linked somehow epidemiologically. Why is it that during sleep that we see this strong link, after sleep, supposed to be a tranquil time, a restful time? Why do these patients develop such a high incidence of atrial fibrillation? To understand this, we have to look at what happens during an apnea. So this is an example of an apnea. We see this in the sleep lab quite often. You see there's what we call flattening of the flow. There's no flow. There's a desaturation associated, and there's also a cardio acceleration as well. And during this event, you can have a surge in both sympathetic or parasympathetic activity, and you can actually get a drop in heart rate or an increase in heart rate depending on which predominates during the apneic phase. But what's clear is always after, and I'm sure, I don't know if everybody sees this, but what you always see after an event is a surge in sympathetic activity and an increase in blood pressure at the same time. And not only that, what also happens is you get this change in interthoracic pressure because of the upper airway obstruction, and that leads to an increase in venous return, which augments also right ventricular preload. And at the same time, because of hypoxia, you get this desaturation as well, and oxidative stress. So to put all of that together, you have 3 main factors: the negative interthoracic pressure, the high sympathetic tone, coupled by the oxidative stress, through different independent mechanisms, eventually leading to atrial fibrillation. And acutely, what that translates to is actually acute atrial dilation, and eventually also a shortened refractory period, triggers for atrial extrasystoles, as well as intermittent conduction delays. And if you can imagine that happening every night, 30, 60, 180 times an hour, which is what we see in obstructive sleep apnea, you eventually get this hypertrophy and fibrosis, which leads to this chronic atrial remodeling, which perpetuates atrial fibrillation. All right, so hopefully now that I hope I convinced you very quickly in the last 2 minutes that these diseases are linked pathophysiologically and also epidemiologically. The question becomes is, okay, clinically, when I see a patient, I have atrial fibrillation patients, what should I do? Should I screen these patients? And how should I screen for these patients? So unfortunately, when it comes to looking at guidelines, the European Society of Cardiology just says in the guidelines, if you have a patient with OSA, you should consider treating them. It's reasonable if you're to screen for OSA, if you have a rhythm control therapy. But unfortunately, it's not really clear when to screen for these patients with atrial fibrillation for obstructive sleep apnea. Obviously, if they have symptoms of obstructive sleep apnea, you go ahead and you screen them. But I've just shown you that there's such a high incidence among them. And the problem is, you can use screening tools like this one. For example, most commonly used screening questionnaire, stop band questionnaire. Everybody's usually familiar with this. Simple questionnaire, tick, 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 easy, in the clinic. There's all of these other questionnaires, the Berlin, the PSQI. The problem with these scores is they're neither sensitive nor specific. The MAP is the best one, and it's only 80% with a specificity of like 40 to 50%. So because of these limitations of these tools for screening, and actually what's interesting in the literature shows a lot of your patients, your atrial fibrillation patients or your cardiac patients, actually may not exhibit any signs and symptoms of OSA. So that's really something that's very interesting, but we don't know why. But for some reason, 60% of OSA patients with cardiac disease may have no symptoms. So what I would recommend, if you do have atrial fibrillation patients, you should screen them. And the way you should screen is by doing a sleep study. Especially if you have a patient, now if they're symptomatic, go ahead and order the test, that's no screening. But especially if you're going for rhythm control, if you have a very obese patient, if you have difficult to control AF, or if you have nocturnal AF, or if you're even going for pulmonary vein isolation, you should probably screen these patients for obstructive sleep apnea. All right. So what does that entail? When you tell somebody screen for obstructive sleep apnea, a lot of people look at you and say, okay, what is a sleep study? How do we get it? And I'm going to try to demystify that for you in a few minutes as well. So in sleep medicine, we have different types of sleep studies, level 1, 2, and 3, 4. The gold standard is what we call the polysomnography. So polysomnography uses EEG, ECG as well, and looks at flow. And this is the gold standard. It's done in a lab, and we score it according usually to the American Academy of Sleep Medicine guidelines. And the advantage of this sleep study, it's the gold standard. It detects all types of events. But the disadvantage is it can be costly, time-consuming, and the wait list can be quite long to get these studies. So that's why we often rely on things that we call portable sleep studies. So portable or home sleep apnea testing devices, which we call collectively level 3 and 4 devices. They're very easy to use. They increase the accessibility. You can give the patient, he goes home, he does the test, and then he brings it back the next day. And it can be performed in any region. You don't need a specialist or a certified technician to give out to patients. The problem with these devices, however, is the warning that these devices come in all different sizes, shapes, and also channels, okay? The American Academy of Sleep Medicine does recommend that if you do a home sleep test, that you have nasal pressure, something to measure chest and abdominal movement, as well as an oximetry signal. And this is what we call a level 3 home sleep apnea testing device. The main problem with these devices is they don't have EEG. And if they don't have EEG, that results in an underestimation of your diagnostic or diagnosis by about 20% in general. So that's why we usually avoid these types of studies for patients with the following comorbidities, like moderate to severe COPD, heart failure, or other suspected sleep disorders, and we go for the level 1 gold standard. But for most patients with atrial fibrillation, obesity, you can simply go with the level 3 type device because it can be easy to use and get. A little bit about OSA testing in Kuwait. There's many centers, unfortunately, still rely on what we call a level 4 device, which is not recommended, which is the overnight pulse oximeter. There's only very few centers available that do level 1. I think there's only 3 so far. We're hoping to expand soon. And there's even fewer centers that score according to the gold standard. And there's no clear pathways for referral for a lot of patients when it comes to testing for OSA in Kuwait. So that's why our group in Mubarak actually, and in collaboration with a lot of our local partners and our international partners, we still are looking to expand the network of sleep studies in Kuwait. But for now, we do accept referrals from a lot of places in Kuwait because I know it's a burden or a difficulty to get patients tested in a lot of the centers or different hospitals in Kuwait. So before I forget, if you didn't get anything of that in the last 2 minutes, please don't order an overnight oximetry because it's never diagnostic. The problem with overnight oximetry, simply put, you might be lucky and you see something like this and you go, aha, this is desaturation, this guy has sleep apnea, perfect. But most of the time, sleep apnea can present like this. There's not always associated obstruction and desaturation. You might get a heart increase, a sympathetic tone increase, which results in what we call a sympathetic arousal. And you see these events with no desaturation, actually. You see this event here, sorry for it's on the bottom. There's no desaturation, but there's a small cardio acceleration from 71 to 92 with this, what we call on EEG, an arousal. And these events, which are actually 30 to 40% of these events, you will never see these events on an overnight pulse oximetry. So you can falsely label a patient as not having OSA by doing an overnight oximetry. And you might say, okay, well, why is that? Why don't we just go if they don't have hypoxia, they might not have that bad of OSA, but that's actually not true. And we know actually from studies like this one, this was recently published by Ali Azerbaijan in Calgary, you can see that even patients that don't have desaturation, but they have change in heart rate, whether that's a low change in heart rate or a high change in heart rate, they have increase in cardiovascular outcome, whether that's fatal or non-fatal cardiovascular outcomes, okay? So please don't use a pulse oximetry to screen your patients for OSA. All right, so in the last few minutes, I'm gonna hopefully, I've shown you or convinced you that you should screen your patients for OSA, and I'm hoping to show you that it's very important, as it is important for me to screen patients for OSA and treat them, it should be equally important to you, the cardiologist, to actually treat OSA. And why is that? So actually, if you look at retrospective data, you can see that patients with atrial fibrillation, if you do treat them, the observational data says that basically patients that you have treated with OSA, you get a risk reduction, relative risk reduction in OSA, atrial fibrillation burden. So this is a small study, retrospective analysis, but if you actually look at the literature as a whole, you see that predominance of this observational studies all show a relative risk reduction of recurrent atrial fibrillation when you treat patients with OSA and atrial fibrillation. So if you treat OSA patients that have AFib, you have an overall risk reduction in atrial fibrillation. And this is consistent, even in meta-analysis, it shows that actually all studies have been shown in observational studies, yes, you treat OSA, you'll get a reduction in atrial fibrillation recurrence. Unfortunately, the only randomized controlled trial that's ever looked at this was published a few years ago that looked at the effect of CPAP on atrial fibrillation and sleep apnea. And what they did is they took about 100 patients, 50 roughly in each arm. And unfortunately, what they saw was the change in AF burden did not change for CPAP patients and compared to usual care, which is no CPAP. So why did this RCT show no effect? If you look into the details of this single, very small RCT, it was underpowered. They wanted to detect the relative risk reduction of 25%, which is really very, very large. And the other problem is they use CPAP for less than 4 hours. And we already know in sleep medicine that maybe we need to treat patients more than 4 hours, especially because as you go deeper into the night, you get more deeper and more autonomic instability and REM. And it's actually this period which we know now that if you use CPAP during this early morning period, you're more likely to get benefit in cardiovascular protection. The other thing is they excluded the sick patients, i.e. the sleepy patients. And I've shown you earlier that you get remodeling, and that might take longer than 6 months to follow for your atrial fibrillation. So that's probably, this study to me is like a little red herring going against the tide of overwhelming observational data that suggests that yes, treatment of obstructive sleep apnea is beneficial. Now, all the interventional cardiologists might say, well, I can do pulmonary vein isolation and finish. No need to do that. So if you look at the data also, you can say that actually after pulmonary vein isolation, one of the strongest factors associated with recurrent atrial fibrillation is sleep apnea or untreated sleep apnea. If you have untreated sleep apnea, there's a odds ratio of 3 of recurrent atrial fibrillation. And there's many reasons why that happens. One of them actually is to do with interprocedural. You might have problem of actual catheter stability because of negative intrathoracic pressure. If you sedate the patient, or if you're doing it under GA, it might be easier, but still you might get these variations with your catheter stability. And again, this is a small observational study that shows over about 60 months follow-up that if you have treated OSA compared to non-treated OSA after pulmonary vein isolation, you definitely have a less recurrence rate of atrial fibrillation. And again, the overwhelming majority of observational data suggests the same. Even after pulmonary vein isolation, you treat atrial fibrillation, reduces the risk of atrial fibrillation recurrence. Unfortunately, again, the same thing applies to recurrent AF. The only published study was last year. That was a small randomized study looking at OSA recurrence after pulmonary vein isolation, and it showed no difference, unfortunately. But it was a very small study, about 30 patients in each arm, and it was underpowered and had a lot of flaws as well. So it's really difficult to say that randomized controlled trials have shown contrary. So to wrap things up, there's a strong association with atrial fibrillation and OSA. You should always have a high index of suspicion for OSA in your atrial fibrillation patients with a low threshold for testing. And make sure when you do get the test that you get the correct test, not an overnight pulse oximetry. And treatment of OSA likely improves atrial fibrillation control and also improves pulmonary vein isolation success rates. Thank you very much.